Let's talk some more about the pathophysiology of heart failure and how it leads to symptoms. So remember, in systolic dysfunction, there's a loss of contractility and a lower stroke volume. And everything's going to be operating higher in the pressure volume curve. So normally if we have a preload of 110 and we eject 70 mLs, that's an ejection fraction of 74%. But with a loss of contractility, we only eject 35 mLs, which leaves an ejection fraction of 32%. So we have a lot of blood left over in the left ventricle at the end of systole. And this is blood that the left ventricle then has to deal with in the next beat. And so you can see how it would be additive, and we're going to be dealing with much higher volumes as we go along beat to beat in systolic dysfunction. Obviously, this is a little bit of an artificial scenario because all of this happens along a continuum and there are compensatory mechanisms. So it's not like we just eventually get so much blood in the left ventricle because, again, there are compensations that happen with upregulation of the renin-tensin-aldosterone syndrome and sympathetic nervous system activation, et cetera. All the same, I want you to think about how, this is my little schematic here, it artificially separates the right side of the heart from the left side of the heart as if we're looking down on the patient. So the left side of the heart, if there's loss of contractility, you can see that blood is going to back up into the lungs, and that's because there's just not as much blood coming out to the body. So there's going to be less perfusion of the body and more blood in the lungs. So we'll talk about how that leads to symptoms of problems in the lungs and symptoms coming from the body. So what will some of these symptoms be? Well, from decreased perfusion of the body, we're going to have fatigue, we'll have muscle weakness. The patient may appear clammy and cool if the heart failure is pretty severe. There may even be altered mental status. In terms of symptoms coming from congestion in the lungs, we of course have shortness of breath, we have dyspnea on exertion. The patient may complain of orthopnea or not being able to lie flat at night or getting short of breath when lying flat. They may complain of paroxysmal nocturnal dyspnea, which is waking up suddenly at night with shortness of breath and kind of needing to sit up on the side of the bed until it resolves. And of course, on exam, there may be crackles in the lungs. The patient may appear dyspneic with increased work of breathing, and there may be hypoxemia. Because of the increased blood, and this is specifically with systolic dysfunction, present in the left ventricle, an enlargement of the left ventricle, you may have an S3 heard on exam, kind of described as a sloshing sound. In diastolic dysfunction, remember that the diastolic pressure volume curve is shifted up and to the left, so the left ventricle is processing at abnormally high pressures. And it's really these high pressures that cause problems because they're transmitted back to the pulmonary vasculature. Again, we can see this reflected in a lower stroke volume and a lower end diastolic volume or preload, but the ejection fraction may actually be normal. So with diastolic dysfunction, you will get some body symptoms of heart failure because even though the ejection fraction is normal, the stroke volume is low and therefore the cardiac output will be low. So these will be similar to systolic dysfunction, although sometimes not quite as profound. So generalized weakness, fatigue, and cool extremities, etc. Where we really run into trouble with diastolic dysfunction is all of the high pressures that are transmitted back to the lungs. During diastole, the left ventricle, the left atrium, and the pulmonary veins all form a common chamber, which is continuous with the pulmonary capillary bed. So an increase in left ventricular diastolic pressure will be transmitted back to the pulmonary vasculature, and the pulmonary vasculature really doesn't like this. Here is a schematic that I found from Up to Date. So it has the left heart on the opposite side of the lungs than I have it in my little drawing. But you can see that the left ventricle, the left atrium, the pulmonary vein, and the pulmonary capillaries are all a common chamber when the mitral valve is open and the left ventricle is filling. You can see that normally the pulmonary capillary pressure is very low, very low compared to systolic blood pressure. And if there's elevated pressures, that not only results in fluid moving from the capillaries into the alveoli, it also causes long-term chronic changes to the actual vasculature and the endothelial walls. So with diastolic dysfunction, you will have those signs of what we call forward failure or inadequate cardiac output going out to the body, but we'll also have those pulmonary signs from increased pressure and therefore sometimes fluid actually in the lung periphery, so in the alveoli and capillary of the lungs. So the patient may have shortness of breath, dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, and on exam may appear dyspneic, be hypoxemic, and may or may not have crackles. So let's talk a little bit about right heart failure. So right heart failure, the most commonly, is caused by left heart failure, and it's similar to what we talked about before. All those chronic changes in the lungs from increased volume in systolic dysfunction or increased pressure in diastolic dysfunction, or commonly both, since both diastolic and systolic dysfunction can occur together, result in increased pressure and volume, chronically affecting the capillaries in the lung, and the lungs and the pulmonary vasculature undergoes permanent changes. And this can result in elevated pressures in the pulmonary artery, and that is called pulmonary hypertension. So elevated PA pressures, which is pulmonary hypertension. So then you've got the right ventricle, which really is not used to functioning like the left ventricle is. It doesn't really usually have to push against pressures that are very high in the pulmonary artery. Now it's having to pump against pressures, very high pressures in the pulmonary artery. So this can eventually lead to right heart failure. So you can see how left heart failure through changes in volume and pressure in the lungs can lead to right heart failure. So you'll have all the same symptoms of left heart failure, but you'll also have symptoms and signs of right heart failure. So increased volume in the peripheral veins leading to elevated jugular venous pressure, ascites, hepatojugular reflux, and pedal edema. Another way that right heart failure can develop is if there's just an inherent problem in the lungs. So when we move on to the pulmonary block after Christmas, we'll talk about changes that can occur with COPD, chronic bronchitis, and emphysema that cause changes in the lung vasculature, elevate the pressures in the pulmonary artery, and lead to right heart failure. And when right heart failure is caused by a problem that originated in the lungs, it is known as cor pulmonale. So it has the word pulmonale in it, but it's actually describing the right heart failure that has resulted from lung disease. So right heart failure caused by lung disease is cor pulmonale. Then at times you may actually have isolated right heart failure, for example, from a right ventricular infarction of the muscle in the right ventricle. And in that case, you will actually have isolated symptoms of fluid elevation in the body, as well as decreased cardiac output to the lungs, which then decrease our output to the left heart, which can result in shock. So we talked a little bit about how systolic dysfunction and how diastolic dysfunction can lead to symptoms and signs of left heart failure as well as right heart failure. Sometimes these are all occurring together, and sometimes they're occurring in isolation. And again, we're not going to be trying to trick you on this with any of our exam questions, and it takes a while to be comfortable with it. This is something we're going to approach over and over again.